Welcome to The Digital Patient, where we discuss the latest advancements in digital patient engagement and share stories from the front lines. Today, we're joined by our very special guest, Dr. Judd Hollander. Judd E. Hollander, MD, is a Senior Vice President of Healthcare Delivery Innovation at TJU and Associate Dean for Strategic Health Initiatives at Sidney Kimmel Medical College at Thomas Jefferson University and Professor of Emergency Medicine. He graduated from New York University Medical School in 1986, completed an internal medicine residency at Barnes Hospital in 1989, and an emergency medicine residency at Jacobi Hospital in 1992. His research interests include innovative care delivery models, including telemedicine, risk stratification of patients with potential cardiovascular disease, cocaine-associated cardiovascular complications, and laceration and wound management. Dr. Hollander has published over 600 peer-reviewed articles, book chapters, and editorials on these topics and other topics. Dr. Hollander was the president of the Society for Academic Emergency Medicine, SAEM, chaired the SAEM Program Committee and Emergency Medicine Foundation Scientific Review Committee, was deputy editor for the Annals of Emergency Medicine, and co-chaired the National Quality Forum Committee to create a framework to support and measure development for telehealth. Dr. Hollander was awarded the ACEP Award for Outstanding Research in 2001, the Hal Jane SAEM Academic Excellence Award in 2003, and the SAEM Leadership Award in 2011. Dr. Judd Hollander, Judd, welcome to the show.
Well, thanks, guys. Nice to meet you.
It's fantastic meeting you as well. I'm super excited for the conversation today. You know, you've accomplished a ton over your career. Just a few examples from the bio, president of the SAM, a distinguished ER doctor and research director, and you've been a mentor to hundreds, if not thousands of students, and were really instrumental in developing and implementing Jefferson Health's telehealth and virtual rounding initiative called JeffConnect. So really just curious off the top, how did you get into this wonderful world of digital health and innovation?
Well, a little bit of luck, evolution, coincidence. They say basically if you're around long enough and you go to the right places, you'll get lucky, right? And so that's kind of what happened. Most of my career, I was an emergency medicine clinical researcher. I ran large clinical research programs. And at some point it dawned on me that the skill set in research, right? Interviewing people, learning from them, collecting data, analyzing data is really the same skill set that you get in business. And so I took a sabbatical and went and started looking at different ways to deliver healthcare, be they urgent care centers and other things, and not actually even connected care or telemedicine at that point in time. And at some point decided to make a career shift and got really lucky in that there was a new supervisionary CEO and a dean at Jefferson. So the CEO, Steve Klasko, wonderful guy, great vision. And the dean, Mark Tykocinski, also wonderful guy, great vision. And they took a gamble on a dude that knew how to do research and said, we'll let you come in here and grow out some of these programs and let's see how it goes. And so I had put together a business plan and didn't necessarily intend to do anything very specific with it. But as an example, there were a group of us. And the example that I gave the dean and the CEO was around telemedicine and how we could work as a Venn diagram. And it turns out telemedicine was in their vision for the future, and pretty much went from a hypothetical thing on a business plan to, why don't you guys all come here and run this for us? So, a little bit of luck.
And Dr. Hollander, I remember reading an interview that you did, and you mentioned Dr. Klasko was a visionary leader who really influenced you diving into telehealth. I mean, it sounded like you came in with that as part of your plan, but was there anything in particular that Dr. Klasko did or said that shaped your views on telehealth going forward?
I think the largest thing was it was about the patient and not about the healthcare system. It wasn't about how are we going to make money today and tomorrow, but it was about how are we going to deliver care 5, 10, 15 years from now. And it was the assumption that consumerism would drive that rather than the payers. And so I think in that, it's not hard to make the blockbuster to Netflix analogy. It's not hard to talk about, the ATM machines, and now it's, banking on your iPhone. It's not hard to talk about Amazon now. It was actually pretty hard to talk about those things 6 or 7 years ago. but it was really his vision, seeing that all of these other areas outside of health moved away from bricks and mortar. And sooner or later, health was going to do that too. And really, if this was Judd in the back room with the same vision, it wouldn't have happened. But when it's the CEO and leader and the board that say, let's do this, and we know we're going to lose money on it right now, then you have a nice long leash to grow out great programs. And so I think it was both his vision and his support and a willingness to say, yeah, we're not going to make a buck on this right now, but we know this is the future. So let's invest in it and get going.
I think it's incredible because it sounds like when the leader of the organization has that level of conviction and that vision, it probably gave you permission to maybe fail along the way and know that you still have an opportunity to get back on the horse and keep marching to the future.
Oh, we never failed. No, I'm just kidding. No.
That doesn't happen in healthcare.
Yeah. Who would fail in healthcare? This is easy. Healthcare is easy. But yeah, that's exactly right. And so, we did something that other places didn't do back then and don't even do now, is we kind of went all in at once. If we had guessed that where would we go, we would have gone to primary care, right? Everything in the world is about primary care. Primary care were our latest adopters. Primary care physicians, primary care providers, they like the face-to-face contact with the patient. They don't want to change. That's their comfort level, right? So we, again, we got lucky because we said this is going to be the future and everybody needs to learn how to do it. And then it turns out the places that grew it out fastest were ENT and urology and some of the surgical subspecialties. And if we sat in a strategic meeting and said, where would we go first? Urology wouldn't have been on that list. Yeah, and so the fact that we asked every department to figure out how are you going to do this and how are you going to make it so any patient who wants it can have a telemedicine visit allowed us to get lucky and grow it out in directions that we would not have been smart enough to anticipate.
I really appreciate the fact that you're looking to the team to collaborate on these things, because I know from your background, you're quite passionate and a lot of your research is centered around cardiovascular activities. And so you'd think, cardiac would be a kind of natural fit, but then going to the rest of the team and really understanding, what's important to them and how would they leverage the technology. One thing that really struck me from doing the research into your background is, in healthcare, often there are these buzzwords kind of thrown around. And something that I really appreciate about you is your take on almost Occam's razor, where often the simplest explanation is the best explanation. And one of the things that I've heard in an interview that you said is, you simply ask others what's easiest for the patient. Could you unpack that a little bit? And what does that exactly mean to you from a digital standpoint?
Well, I think that starting at the 10,000 foot level, I don't know, most people who know me wouldn't consider me a person full of humility. They'd probably think the opposite. But in fact, as I often like to say, for someone who often talks over people, I'm a pretty good listener. And most of the ideas that I've gotten credit for in my life, in fact, maybe all of them, weren't my idea. But they were taking something I heard somewhere else and being able to unpack it and execute on it when other people may have had an idea and not figured out how to go forward. So at the end of the day, I think the world's about three things. It's about business. There has to be a business model for things. And the way you think in business is the way you think in your home, right? It's, can you afford to add this addition to your house? It's how are we going to do, how am I going to pay off the credit card? Can I afford to buy this? There is some economics in everything. So you need to understand how that is, and you need to understand who you're selling it for. Then there's an element of psychology. And so you have to figure out, where do you need to apply that acumen? Now, I need the patient to want to do it if it's going to be a patient-oriented solution. So I need to know, what do they want to do? But I also know in our system, I didn't at the time, that 75% of the patient decision is driven by the provider. So I need the provider to know, to buy into this. So I need to know what the patient wants, and I need to make it easy enough for the provider to convince, not even convince, to just suggest to the patient. And since it's what the patient wants, they'll do it. But if I can't get the provider to say, your next visit's going to be on telemedicine, It's never going to be on telemedicine because the patient's never going to ask. And then the last part is marketing and salesmanship. How do you convince people to try it? And I think if you understand there's an economic model that makes it work, it's what people want, give them what they want, and then tell them why they want it, or at least explain why they may want it, you can go forward. And I think the same was true in the research world. You know, you're deciding it's an important problem to solve. Well, who gets to define it as an important problem? It's got to be the person who's going to fund it, the business, and the end user who's going to use it to make it worthwhile. And I don't think digital health, connected care, telemedicine is any different than that. And frankly, that's the same as the rest of your life, I think.
I love that. And Dr. Hollander, I wanted to go back a little bit and unpack something you mentioned. One of the really exciting and unique things about JeffConnect, as you said, is that you didn't do it as a pilot, right? From day one, you went all in. It's an operational thing. We're going to provide it to urology and everyone else. But as you know, better than we do, health systems often like to, let's call it quote unquote, pilot new innovations. But, you know, we've seen that result in maybe slow progress. Maybe it's even doomed from day one because the pilot isn't structurally set up for success in the first place. Is there a reason why it made sense for JeffConnect to go enterprise from day one? And in general, like, do you think there are scenarios where it makes more sense to go all in from day one as opposed to a pilot for a new innovation?
Well, so I think it depends on how much you believe in it. I think by virtue of, I mean, Alan, when he was, you know, given my bio, knew that I chaired the SAM program committee. If you submitted an abstract when I was program committee chair and you said, this is pilot data, you pretty much weren't getting accepted to the meeting, because what that really means is you did a resident project, which wasn't very well done. You couldn't enroll people and you didn't get enough data to make it useful. So you called it a pilot project. So a lot of times pilots are failed big projects. So a designed pilot is something different where you're looking to see if it works. But you know what? If you're going to grow out telemedicine and you need to figure out how to train the doctors, and you need to figure out how to get it incorporated into the IT system, and you need to get patients on board, that's a boatload of work. That's a ton of work for 10 people. It's not that much more work for 50 people. And so we've always approached it like, how would we do this at scale? And then how do we learn? So we started, and when we first rolled out, Jefferson's an interesting place if you know anything about Jefferson. When I came there in 2014, we were a 3-hospital system. Now we're 18, and we've added them in chunks of 2, 3, or 4 along the time, which means I've had the unique experience, we'll call it a good experience, maybe not every day, on rolling out telemedicine again and again and again to groups of people from new health systems that really didn't do telemedicine before. And so when we first did it, there were 500-600 docs. We had 20 sessions. We put 20 or 30 people in a room at a time. We, you know, got them up on the platform. We got all their information loaded. They put in their pictures, their bios. We showed them how to use it. They did a couple practice tests. 2 hours later, they were trained, and the next group came in. That might not have been the most efficient way, but it was the easiest way to get everybody trained on something nobody knew for us at the time. Well, when we added another health system, now the people that worked doing the training didn't live that close to that area. So doing 20 sessions, that's a hassle. So we ended up developing remote training. And so, you know, it might be done like we're doing this podcast over, you know, a video chat. But then ultimately, when COVID hit, and we had done this by the time COVID hit, we had learned how to train people by videos. So it could be online modules. And so we actually trained 1,000 people in a week, the week COVID hit the Philly region. And the first thing, we had the video modules trained for people doing scheduled visits, which is the majority of our health system. But we had a small group of 15 or 20 people that did on-demand visits, direct-to-consumer on-demand visits. And that volume went from 20 a day to 300 a day. And we needed more people trained to do that. So the first thing we did is we said, remote training worked better than in-person training. Let's rent out a film studio and go do the film so we could train up other people. And we had like cardiologists and GI docs willing to jump on the on-demand platform and help out early in COVID because no one was coming to their offices, and we're able to train them. So I think that if you think about what's scalable and durable and build for that, it doesn't take you that much more work compared to a pilot program.
No, it's a great point, because you've basically put on the work to build out the infrastructure for the initiative, and then just enrolling or inviting more patients is just a little bit more work, but the bulk of the work was done up front. So I think that's a really great point. You mentioned just now the explosion of telehealth use and JeffConnect during COVID. And I think, Alan found data that JeffConnect went from maybe 10% of patient interactions at Jefferson to well over 90% at some point during the pandemic. That's a huge amount of growth. Probably a lot of logistical hurdles along the way. Just wondering, what would you say were the biggest hurdles you had to overcome to kind of basically support that growth almost overnight?
So I'm not sure this would be the same for everybody else, but it was the economics around licensing. We staying somewhat vendor neutral and not giving the names, we had, a license to do X number of calls, and we were doing 20X number of calls. And, the company at the time could have said, yeah, we'll give you 20X, it's COVID, let's be nice. But they, wanted to increase the rates. We were at that time planning on swapping out the video, the one I was talking about, for another one, which we thought would work better for us down the road. And, you guys run a tech company, right? So, what are the likelihoods of moving up your integration by 11 weeks in the middle of a pandemic? And we did that. And God bless everybody involved in it. My tech team, I may not be exactly right on this, but they basically didn't sleep for 11 days. Wow. And they did rotate out for 2 or 3 hours of rest at times. And we accelerated, with the help of our corporate partners on the other side, the integration of a new video module into our EMR, and got it done in 11 days, which allowed us to both save money, be more efficient, and provide a better provider and patient experience. And we had go, no-go decisions with 4 corporate vice presidents on the phone at 1 a.m. Wow. And now, because we couldn't do all the testing you normally do, we had to build a toggle switch so that if the new system didn't work, we could shut it off, go back to the old system, and buy the increase in licenses. So it was, I think everybody realizing that this was a game-changing pandemic at that point in time, and everybody doing everything they could do, and believing that one day it was going to end, so you could do this for 11 straight days. Nobody thought we'd be doing this for 11 straight years or whatever it'll turn out to be. We had the devotion, we're able to make it work. And so the biggest challenge was clearly that, was scaling up and having to launch tech solutions without the appropriate testing and building, the release valve in case it didn't work.
Yeah, no, that is absolutely incredible. I think I even saw on your Twitter like a photo of a couch being converted into a bed in your office, and that's you had to do what you had to do, kind of thing. Just actually kind of speaking on that, another really interesting tweet that I saw.
Let me just tell them, I just want to say publicly, you should avoid Alan, because he finds more dirt on the web from you than anybody else I've ever met.
Or just don't let dirt surface up on the internet.
Well, that's another solution too.
So speaking of, some of the dirt on your Twitter back in 2020, this is not dirt at all. This is actually amazing. I saw a tweet from you basically sharing how the velocity of calls using JeffConnect from patients was sort of an early indicator on the declining COVID rates that you could see. And so I was curious, do you think this insight still holds true today, or?
Oh, unbelievable. I am like such a firm believer of that. And it's funny you ask now, right? Because we're just getting over the Omicron surge. And so I'll say 2 Saturdays ago, I sent an email to, my bosses at Jefferson as hospital rates were going through the roof. And I said, good news, we dropped 70% in our phone calls in the last week.
Wow.
And everybody had like fingers crossed. And we are now on JeffConnect back to baseline.
Wow.
In urgent care, we're below baseline. And I mentioned I ran the urgent care centers too, I think, when we were talking. And we went from 40 to 60 patients a day to 120 patients a day. Talk about tapping out a bricks and mortar place. It's brutal. And we are now back to below our baseline volumes there. And for 5 or 6 days in a row, our hospital volumes have fallen significantly, and we're probably down about 30%. So not only do we get to see the up, but we get to give people hope that the down is coming soon too.
That's awesome. I had a follow-up, but you pretty much did answer it, but I was curious, do you think other health systems can use telemedicine visit data to kind of evaluate or predict incident rates? It sounds like yes is the answer.
Well, so I think it depends how you do it. So I'm not sure my urology visits would have shown this, but it's because we have an on-demand program where people are calling in, and because we coordinate COVID testing through that on-demand program, anybody who starts getting COVID exposures, and there's an era before rapid tests are widely available, would call us to do that. Whether or not this will work 3 months from now, if rapid tests are widely available, I don't know. People may just go get the tests and we may not see the impact, or we may see, just not as sharp a curve up and down.
Right. Yeah, that makes sense.
And Dr. Hollander, you've obviously been very involved not only in telemedicine at Jefferson, but in paving the way more broadly across the country. So in 2017, you co-chaired the National Quality Forum Committee to create a framework to better support measurement development for telehealth. And for folks who haven't seen it, in the report, your committee identified 6 key areas to measure for telehealth performance: travel, timeliness of care, actionable information, added value of telehealth to providers, evidence-based best practices, patient empowerment, care coordination. Now, that was before COVID. Telemedicine has exploded during COVID. You have way more data, way more experience now. I was wondering, if your committee was to meet again today, do you think you'd be recommending any different measures? Would you change anything?
So the items you just named are all important. I think they were important pre and during and post-COVID. But there's 4 actually domains that I would like to highlight that are maybe more important that those 6 things fit into, which are access as a domain, cost and finances, experience, and effectiveness. And so the way you worded the question was great. It turns out to be a softball and you didn't know it, because there's been multiple other National Quality Forum and other groups getting together to do different frameworks for telemedicine. And the 4 things I just named still fit into all of them. Many of the groups have struggled with, but have added a 5th, equity. And I wouldn't argue that equity is not important. Equity is clearly hugely important. I just think it's a sub-piece of access, and a sub-piece of cost, and a sub-piece of experience, and a sub-piece of effectiveness. So it fits within that. Josh, the things that you named, the one that I would say the most about is actionable information, because I hear something that just, it drives me insane every time I hear it, when it talks about the diagnostic accuracy of telemedicine. And there is no diagnostic accuracy of telemedicine or an office visit, right? You go see your primary care provider, and what do? They order a bunch of labs, an EKG, a test, an X-ray. The office visit, they didn't diagnose you. The composite of the care diagnoses you. So a fail is if you go see your primary care doc and they miss the fact that you need a CAT scan to diagnose appendicitis. That's the same fail in telemedicine, but don't expect me at the end of a 10-minute video visit to have your diagnosis right. Just expect me to do the right actionable next step. And so that's one of the things that kills me when I hear diagnostic accuracy, because it's really about actionable information. The other important point to highlight in this is that comparisons are often made between telemedicine and a visit that happens in person. And that's a horrible comparison. And this is real data, and we've published this in the New England Journal Catalyst. If you're doing an in-person visit, there's a 25 or 30% chance your appointment tomorrow, you don't go to. You either cancel or you're a no-show. If you have a telemedicine visit tomorrow, that's only about a 14% chance you miss that visit. So even if telemedicine is not as good, but is nearly as good as an in-person visit, it's way better than you not showing up. So the right comparison is a telemedicine visit compared to your best alternative, which 25% of the time is nothing. So yeah, I mean, if you just compare it to the gold standard when everybody shows up, that might be different. It might not be. And in some areas it likely is, and in some areas it's likely not.
Yeah, I think to your point, I don't get why I think sometimes some folks are too obsessed with one size fits all medicine. I mean, to your point, there are certain interventions or tools like telehealth that are going to be more appropriate or less appropriate depending on the situation. And I think it's about how do we get the most appropriate form of care or modality to the right patient at the right time. And maybe we can argue about how do we get closer to that. But I think it would be strange to think that telehealth wouldn't be more useful or more convenient than an in-person visit in every situation. I think that would be strange to expect that. So I think to your point, we have to be practical about it, and we can, in some ways we can't be overly academic about it.
Right.
So I think that's completely fair. There's been an explosion now of patient-facing innovations in digital health beyond, telemedicine now, and probably COVID helped accelerate that. So, there's digital patient engagement. So for example, maybe engaging patients digitally, pre and post surgery, monitoring symptoms, post-op, et cetera. We've seen lots of chatbots exploding, maybe triaging service on your hospital website, and probably many others that you're looking at. What are you most excited about as a health system innovation leader going forward?
I think that, that's a really tough question. I think I'm most excited about doing what patients want to have happen. And I think in the end, that's what needs to happen. Where health system is broken, besides staffing and the COVID workforce challenges right now, is that at the end of the day, it's all driven by the payers and insurance companies and reimbursement. And so I'm excited to get to a point where it's driven by the patients. Like, it is insane to me, and this is one of my rants, and this Alan's probably been on Twitter too, is you take $15,000 from an employee, right? Or the employer and the employee combined to pay $15,000 for their family to have health insurance, and then the payer doesn't pay for it. Why are they called the payer if they don't pay for it? They're the taker. They're taking the money, but they're not giving anything back. And so it seems to me that we have to get to a marketplace where the patients could shop for the services they want, letting the employers shop for the best rate for an insurance company that doesn't give the patients what they want isn't an appropriate market in the United States. The employees are just stuck with whatever the employer provides. It'd be one thing if they gave you 5 different options with different insurance companies and made the insurance companies compete on care. But I think we need to get to a point, and we might, because there's enough, non-payer, providers out there that will open up access to care. It's not clear to me there's enough employers who will allow that. But I look forward to seeing disruptive payment models driven by disruptive technology to provide more patient-focused care.
It's funny you mentioned that, because it reminds me a lot of what we deal with up here. So I don't know, Judd, if you knew that. So Alan and I are actually based out of Toronto. So we're in the Canadian publicly funded healthcare system. And I can tell you, even though everyone here as a healthcare provider is well-intentioned, we're very much focused on the patient experience and the outcome. But because of the global budget model, let's say hospitals are under here, even if we have an intervention that reduces readmissions or complications or mortality, because we're not primarily funded based on value-based models or performance, our executives here have limited economic incentives to adopt things that improve outcomes. Because if they've told me many times, hey, if we save money here, the government thinks we need less money next year. So we don't really have as much of an incentive to do things at lower cost and improve quality, which sounds crazy as a consumer, as a citizen, as a patient, but is kind of the reality we're often dealing with when it comes to payment models. It's crazy to me sometimes, but it's not. I think it's maybe a bit better in the U.S. or in many ways.
It's no better in the U.S. I will say it's actually better at Jefferson, which is where I work, which is my small neck of the world. In that, we try to be cost conscious and we try to deliver the best possible care to patients. And I don't believe in our heart of hearts, there's a lot of people running around just trying to, keep money in their budget for next year. Like, I think we reward when you cut money. And I, certainly make it a priority to make sure I'm making my budget, and where I could save money, I'm saving money. And in return for that, I hope when I ask for money, people understand that I really need the money and I'm cost conscious. And that's what I find. I have been other places where people did exactly what you just said, which is, oh my God, it's the end of the year, we better spend $100,000 or the $1 million that's left. That's insane. That is the most irresponsible thing ever. And so I'm just grateful I found a place that actually, I'm able to show that I could be a good fiscal steward, that they could trust me. And then when we need the right thing for patients, we get it. And I don't have to worry about building up a war chest and hiding it under the table for next year.
Yeah, totally makes sense. I am still just amazed at the fact that, you started this whole digital health initiative like 7 years ago, 6 years ago now, 7 years ago. To me, that's still incredible because it was just so progressive for its time. I'm curious if you could give advice to any other, digital leaders in healthcare today regarding adopting a telehealth strategy or a digital front door strategy. What would your advice be?
Make a digital mRNA vaccine. I think that would be the best thing you could do. But yeah, I think that my advice is, and we got lucky because we weren't doing this to scale up during COVID, but we were doing it to scale up when value-based care took on, a little more in the US. But we actually almost scaled up too fast because you can't outpace the reimbursement models too much. And so then we spent a lot of time, and we still do, talking about right-sizing it, which is knowing you have it ready to scale up when you need it to scale up, but not scaling up where you're going to lose your shirts, beforehand. So I think my advice would be build it so that you're ready to scale up. And we went for, in many ways, the premium model across the board. And so I think that each health system needs to figure out, where do you need the premium model and where do you need a model that's just good enough at the time being. But it worked for us doing what we did. So I think if I went back and did it over, there'd be a few things I would do different. But I'm not sure they're helpful for, another health system because, you've seen one health system, you've seen one health system.
Right. And Judd, as obviously we're navigating new COVID variants, and with Omicron now, and I mean, even beyond that, in a post-pandemic world, hopefully we get there, now that we've experienced, I guess, telemedicine changing over the past 2 years, increased adoption, maybe decreased adoption, and bouncing back and forth. What aspects of patient communication at this point do you think virtual has almost completely replaced? But what are the things that you think will, most likely go back to face-to-face long-term?
So I think that, and you said this earlier on, I think, we're never going to be all in person and we're never going to be all virtual again. And, it's going to be driven by the patient, and people should stop guessing what the patients want, because there's an easy way to figure out what the patients want. Just ask them. And so, a couple examples. I got a dad that's 88, that's, got a whole host of chronic medical problems. And you know what? He can't do a video visit on his own, but he can't drive either. So if my sister, who's the one who lives near him and is, the primary caretaker, would she rather go to his place, put him on the iPad, or would she rather go to his place, pick him up, drive him half hour away, and drive him back? Right. So a doc may think, oh, this old guy, he can't do telemedicine, but that doesn't mean telemedicine is not the best thing for him and his caregiver to make it happen. The other areas that we've seen that are unique is bad news. Every doctor thinks every patient wants to be sitting there holding their hand when they're getting bad news. You know what? Not every patient wants to do that. And my analogy that I often give is, imagine you're in a minor fender bender car accident. In my world, you're shaken up for hours after that. And all you did was like bruise a bumper of a car that's now going to be a pain to fix, and you have no injury and you're still jittery. Now, thankfully, it hasn't happened to me, but imagine being told you have cancer. And if you live 75 miles away, do you want to drive in, even with your spouse or significant other, be told you have cancer so that the doctor could look you in the face and tell you this and then drive home and then tell all your family? Or would you rather be on a group video where your family's wherever and you and your spouse, and if the kids want to be with you, they could find out the biopsy results at that time? And I'm sure there's patients that want to be there in person. And I'm sure there's patients that would prefer the couch with all their family back home. And so I think we need to do a better survey of what patient preferences are, because that's a really important conversation. The information is going to be transmitted. The next steps are going to be the same, but let patients have care the way they want.
I really love that. I mean, one of the stories that we've had personally here is, we used to sit down next to patients and watch how they'd interact with, digital platforms and see what they could actually access. And I remember, like, we used to sit down next to patients in their 70s or 80s, and they may have an iPad, but then you realize quickly that they don't even know their app store password. So they need to use the web browser to interact with that application. And it's a light bulb moment about how does that patient need to be reached given their circumstances? And it isn't one size fits all. So I love the fact that you're absolutely right. I mean, what came to mind when you're describing that scenario is, like, what if I'm a patient, I'm on my own, I'm driving in, I'm getting told I have cancer, I have to drive myself back. Might be safety issues there if I'm thinking about encounter. It's wow.
Right. And, it's interesting. because my father, who can use his iPad until he shuts it down and then he can't log back on to Wi-Fi because he doesn't even know his Wi-Fi account, an ongoing issue we're really having. And my uncle, who just got discharged from the hospital, who owns neither a cell phone nor a computer, but is heavily invested in the stock market, probably the only human being heavily invested in the stock market without a cell phone or a computer. But I get a phone call. He's just discharged Saturday. And I get a phone call. He lives 150 miles away from me. I get a phone call today from the home health nurse saying, we want to do med reconciliation. I'm like, I don't know what meds he's on. No one called to tell me. He's not here. And and he's not answering his phone because it's from a number he doesn't recognize. And he only has an answering machine because my wife and I brought him one because he didn't want one. Or you could never reach the guy. Like, people are just different. It's a different approach. Like, they should have had somebody meet him first, and she could have said, this is the number I'm going to call you from, answer it. And he would have.
It's funny. So much of medicine has nothing to do with clinical medicine at all. Like, we know all the right things to do. It's the patient education, it's the communication, it's all the other things that were nothing to do with clinical medicine.
Yeah, that's incredible. Super fascinating. I'm just short on time, Judd. So we're going to flip over to what we call the Fast 5 lightning round. Basically 5 questions to get to know you a little bit better for our audience. They're pretty quick. First question we have is, what is your favorite book or book you've gifted the most?
So I'm not a huge reader, but one of the books I read most recently that I love the style of was Michael Lewis's book on the pandemic. And I thought that was really well written, and it followed a different format than most books I've read, in that each section highlighted a person and how they were impacted and their role early on the healthcare side of things. And I actually found it a very enjoyable read and very enlightening to stuff as a guy heavily invested in the pandemic and what was going on in the background that I didn't know.
No, that's awesome. Question 2, this is specifically for you: Eagles or Cowboys?
Oh, there's no Cowboys anywhere. It's the better question. See, this one you blew, because you could have done Giants versus Eagles.
Fair.
Because I grew up in New York.
Yeah, that's true. Yeah.
I would recognize the accent. And I was probably a bigger Giants fan than Yankees fan. And when we moved to Philly 20 plus years ago, I've kept my Yankees allegiance. Sorry, Phillies. And I switched to the Eagles. Wow. Even though I was a huge Giants fan, in part because, and this is, a rooting thing in our family, my son was friends with Andy Reid's son, who was coach of the Eagles. So we're, became big Eagles fans, and he got to go in the locker room and, be at the sports complex. And now we're rooting for the Chiefs. So yesterday was a very good day.
Yeah. Best game of the day.
Yeah.
It's an unbelievable sports weekend this weekend.
Oh, my God.
Incredible. All right. Question 3, would you rather have super strength, super speed, or the ability to read people's minds?
Probably, well, I don't know. I don't want to know if I want to know what people are thinking. Can I just opt with, I'm grateful for what I have right now?
We haven't had that answer. That's good. Yeah.
You're the first person who's actually content with what they have. That's impressive.
That's awesome. Question 4, what is something in healthcare you believe that others might find insane?
That others might find insane?
Yeah.
The fact that the doctors have very little say over your healthcare decisions when they're important. And the fact that it is driven by economics of people who don't have any vested interest in your outcome. And so I'll elaborate for one sentence on that. Commercial payers, the average time a commercial payer has your policy, I believe, is less than 3 years in the United States. So if you're a diabetic, they don't want to spend money on you in the next 3 years. Whether or not you develop renal failure or a stroke or retinopathy 30 years down the road, not their biggest priority. Our incentives are misaligned in healthcare, and they are not what patients would want.
Yeah, no, that's profound and accurate. Question 5, this is a pandemic lockdown related question. What is one hobby or activity you've gotten into since the beginning of the pandemic?
Oh, well, we talked about this before we were live on the air. It is tennis, and more tennis.
Yeah.
So I, as I was saying, Alan and Josh, before we got started, back in the days when I was young and healthy and could run around, I played high school and college tennis and, hacked around over the years and tried picking it up again recently. But my gift to myself, now that we were never going on family vacations or in fact spending money on anything because we were locked down in the house, was to take tennis lessons again. So that's the answer to that one.
That's awesome.
A quick follow-up, Judd, favorite tennis player of all time?
Favorite tennis player of all time? Oh, that's a tough one. So, I can picture him, but I'm blanking on the last name. VJ, before your time, big blonde curly hair. Anyway, because I sat next to him at the U.S. Open. And go ahead, Alan, Google him.
Yeah,
and he sadly died of carbon monoxide poisoning a couple of years later on Long Island. But back when I was young, growing up in New York, the U.S. Open was there, still is there, but was in Forest Hills. And when you went and sat on the side courts, you could just be sitting next to the players or walking around with the players. And his sister was playing a match, and he was like 16 years old. And we sat next to him, and he just chatted with us the whole match.
That's awesome. Are you talking about VJ Amritraj?
Yes.
Amritraj?
Yeah.
Okay.
Yeah.
I actually don't know him.
Yeah, he probably creeped in the top 10 at some point, but was a super nice guy.
Wow, that's incredible. And you, Judd, we did speak before the recording started, but it sounds like you're playing like every day almost.
No, not quite every day, but I'm if I get out 2 times a week is now my low. That used to be my high.
Right.
And periodically I could make 4 days a week without my body feeling like it's going to fall apart.
Yeah.
if 2 days were my low, I'd be pretty happy. I mean,
That's incredible. Well, awesome. Judd, thank you so much for coming on the show today. You've shared a ton with us, about telehealth and digital front door and just your strategy and your thoughts on how we're progressing through COVID and even, started before COVID and how health systems today can really move forward as we kind of go into this digital era moving forward. So thank you so much for coming on the show and sharing your wisdom with us today.
All right. Thanks, guys. Pleasure talking to you. It was fun.